gland, one of the trickiest glands to work with in an aesthetic field. So first of all, the adrenal gland, as we all know, it consists of two parts, the adrenal cortex and the adrenal medulla. The adrenal cortex, we all know, it have three zones, which we used to call the zona fasciculata, glomerulosa, and reticularis, that secrete three types of hormones, and the adrenal medulla, which secretes the catecholamines. So the cortex give us the glucocorticoids, the androgens, and the mineralocorticoids. The glucocorticoids are the cortisol, mineralocorticoids mainly aldosterone and the other androgens. And the medulla gives us the catecholamines, primary epinephrine and norepinephrine, and some dopamine. But it's 80% and 20% epinephrine and norepinephrine. The hormone regulation is very important. As for the cortex, we are talking about the hypothalamic pituitary adrenal axis. So the hypothalamus sends signals, hormonal signals, to the pituitary, and from the pituitary gland to the adrenal gland to secrete glucocorticoids and mineralocorticoids to keep this homeostasis in action in terms of fluid and electrolyte balance and glucose maintenance and stress reaction. To simplify this diagram, we know the hypothalamus releases the corticotropin releasing hormone here to the pituitary gland that releases the adrenocorticotrophic hormone here to the adrenal cortex, which gives us glucocorticoids and mineralocorticoids, whose level does a negative feedback mechanism on both hypothalamus and the pituitary gland to stop the secretion of CRH and ACTH. But the aldosterone has a different mechanism controlling it as well, which is the renin-angiotensin-aldosterone system, and this is very important. So to summarize this part, we have the ACTH from the pituitary gland stimulates the secretion of both cortisol and aldosterone, but the aldosterone can be stimulated by the renin-angiotensin-aldosterone system as well. But for the medulla, it's not affected at all, but this regulation. So the adrenal medulla is not connected to the hypothalamus and the pituitary. They are connected to the sympathetic nervous system because they are modified sympathetic ganglia. So we have the output from the lateral horn cells in the thoracic levels or thoracic segments of the spinal cord, the sympathetic ones, with the preganglionic fibers going through the greater and the lesser splanchnic nerves without relaying in the celiac ganglion, but they relay first in the adrenal medulla, and they are cholinergic preganglionic nerves. So they stimulate the adrenal medulla to excrete its contents of the adrenaline and noradrenaline. And this stimulation can happen because of many things like exercise, hemorrhage, surgery, hypertension, hypothermia, hypoglycemia, hypercapnia, hypoxemia, pain, and fear. So if we look at this gland, this adrenal gland, we will find two parts, as we said, which is the cortex and the medulla. And we can look at it as that the medulla is responsible for the immediate response for stress, but the cortex is responsible for long-term homeostasis in the body in terms of electrolyte and fluid. So what actually do these hormones do? If we talk about the aldosterone, which is a mineralocorticoid, and the mineralocorticoid means it affects the minerals. So it's about fluid and electrolyte balance in the body. The renin-angiotensin-aldosterone system and the pituitary gland goes to the suprarenal cortex, stimulating the aldosterone. And the aldosterone then goes straight into the kidney nephrons. And to know what more it does, let's have a quick look inside that nephron. It goes to the distal convoluted tubules and collecting ducts, and mainly affecting the sodium reabsorption. So it increases sodium reabsorption, as we can see here. And when the sodium is reabsorbed, we all know that the water will follow it back to the body. So it's sodium and water retention here. And in exchange of sodium reabsorption, it excretes potassium. But distally more, the potassium is exchanged back with hydrogen ion. So putting hydrogen ions in the urine and reabsorbing some of the potassium that has been excreted. So the net result is sodium and water retention or reabsorption, hypokalemia because we lose potassium in the urine, and metabolic alkalosis because we use hydrogen ion in the urine. And if we talk about the cortisol, which is a glucocorticoid, it has several functions. After being stimulated by pituitary gland, the adrenal cortex secretes cortisol as a glucocorticoid, and it goes to the liver, affecting protein catabolism and does some gluconeogenesis. The cardiovascular system is very important for responsiveness to catecholamines. So if we don't have a glucocorticoid circulating, whatever catecholamines we use, the blood vessels and the heart do not respond to them. And kidneys, it has a weak mineralocorticoid effect, which is doing exactly what the aldosterone does, but a little bit weaker. And immune system, it causes immunosuppression and slows healing. And when we use glucocorticoids externally as exogenous cortisol, like dexamethasone, it has therapeutic effects and other side effects. The therapeutic effects, as we can see, it's pain relief, anti-allergic, immunosuppression, anti-inflammatory, but it comes with lots and lots of side effects, starting with infection, myopathies, osteoporosis, skin thinning, hyperglycemia, and many more. The adrenal medulla, it secretes catecholamines, as we said before, and its functions all over the body, depending on which receptor and which part of the body we're talking about. Now, abnormal physiology with the adrenal gland happens if we have an increased secretion or decreased secretion. And the increased secretion means hormonal excess, and that can be either aldosterone, cortisol, or catecholamines. The aldosterone happens because of a secreting adenoma or bilateral hyperplasia. The cortisol, if we have a suprarenal cortical adenoma secreting cortisol, and the catecholamine, if we have an adenoma secreting catecholamine in the medulla, and we'll talk about them. The first one is called primary hyperaldosteronism or Conn's syndrome. The second is Cushing syndrome. And the third is Pheochromocytoma. And it's important to notice here that here it's called Cushing syndrome, not Cushing disease, because Cushing disease happens when the disease is in the pituitary gland, not in the suprarenal gland. Cushing syndrome is a syndrome with an increased circulating cortisol or glucocorticoids in general, whatever the cause is. But if that cause is an adenoma in the pituitary gland secreting ACTH, forcing the suprarenal cortex to secrete cortisol, this is called a disease, Cushing's disease. Where are we going to meet these patients? So the first one, which is the first two actually, the aldosterone secreting adenomas and the cortisol secreting adenomas, they can come to us as anaesthetists, either to have these glands removed or coming to have another surgery not related to this gland, but they have this disease in the background, and we need to know how to manage them. And the catecholamine secreting adenoma, which is the pheochromocytoma, they will come to us just to have this removed because they can't have anything else done unless this is not in the body. And as we can see, the disease as well can be in the pituitary gland, secreting more ACTH because of an adenoma in the pituitary gland going to the adrenal cortex, causing secondary hyperaldosteronism or Cushing's disease, as we discussed. And the secondary hyperaldosteronism can be because of another reason as well, which is heart failure or cirrhosis. This is decreasing the rate of eliminating aldosterone rather than increasing the rate of production. And it can be secondary to increased renin, angiotensin, aldosterone system activation. And for the Cushing disease, there might be an ectopic secretory adenoma in the lung, excreting ACTH rather than the pituitary gland, causing the Cushing's disease. And again, the same question, where are we going to meet them? They're either coming in your pre-assessment clinic for the operation to remove the source of the hormonal problem, or they are coming to us to have another surgery not related to the endocrine problem at all. Decreased secretion is another problem. If you're talking about mineralocorticoids alone, this is something. If you're talking about glucocorticoid, this is another thing. But in fact, those two things always happen together. They are never isolated. So hypoaldosteronism and low glucocorticoid circulation in the blood, those are the same thing. They happen together. So let's take this off the way first, which is the catecholamine deficiency. we need to understand that catecholamine deficiency doesn't happen because we have removed the suprarenal gland, because the catecholamines are produced elsewhere in the body. So if we have a catecholamine deficiency, this is because of the process of manufacturing the catecholamines. There's deficiency in the precursors or in the enzymes that leading the process. But removing both adrenal glands doesn't lead to catecholamine deficiency. But removing both adrenal glands will lead to mineralocorticoid and glucocorticoid deficiency. And looking closely at those, we call them adrenocortical insufficiency. They can be either iatrogenic, and that happens because we are giving this patient glucocorticoids. We are giving them some steroids, and that will inhibit the axis, the hypothalamo-pituitary adrenal axis. And the kidney or the suprarenal gland will stop secreting those hormones. Or an endogenous reason. Our endogenous reason of adrenocortical insufficiency, we need to understand why. So it can happen either here in the cortex. So if we have a problem in the suprarenal cortex, that means the factory itself is not going to manufacture those hormones. So we will have very low cortisol, androgens, and aldosterone. All of them will be lost. But we will have lost negative feedback mechanism. So the periventricular nucleus in the hypothalamus will keep secreting the corticotropin releasing hormone, which will stimulate the pituitary gland to secrete more adrenocorticotrophic hormone. So in Addison's disease, which is the primary adrenocortical insufficiency, we need to understand that the factory itself is not working, no hormones at all, but the stimulating hormones are high, and this is how we diagnose it. But in the secondary adrenocortical insufficiency, which or exactly in the end, we will lose two hormones, which are the cortisol and the androgens, but we will have normal aldosterone levels in the blood. That's because it will be secreted or stimulated by the renin, angiotensin aldosterone system. The factory itself is intact, but the stimulating hormones are not working. So what we will find for the diagnosis is that we have the corticotropin releasing hormone coming from the hypothalamus, but the pituitary gland is not functioning well. So we will lose the adrenocorticotrophic hormone, and the end results: low cortisol, low androgen, normal aldosterone, high corticotropin releasing hormone, low ACTH. There's a tertiary type of adrenocortical insufficiency, which we have a problem here in the hypothalamus. That means the CRH is not going to be secreted, and as a result, the ACTH is not going to be secreted. And as a result, the cortex is not going to be stimulated through this pathway. So again, we lose the cortisol and the androgens, but still the aldosterone will be there because the renin angiotensin aldosterone system is still functioning. So this is how we differentiate between those three types. But there is one more type, as we said, which is the iatrogenic type. And it actually mimics the last type, which is the tertiary, as if we don't have any stimulation coming from the hypothalamus. And that's because any source of glucocorticoids going into the systemic circulation. So exogenous glucocorticoids in the systemic circulation, it can be oral, it can be inhaled, intravascular, it can be topical creams and stuff if we take them long enough, or intra-articular injections and injections that we do for pain therapy. And all of them will lead to high concentration of glucocorticoids in blood, giving negative feedback to hypothalamus and pituitary gland. No CRH, no ACTH, and again, no cortisol in angiotensin aldosterone system. This curve shows how the body responds to glucocorticoids, exogenous glucocorticoids, and when it recovers after stopping them. So this is point 0, 2 months before glucocorticoids for 2 months, and then at point 0, it stopped. So we'll find the recovery of ACTH happens first, and it takes about 2 to 4 months until it reaches the normal levels of ACTH. and then it peaks up because the cortisol level will remain low, and the cortisol will recover in about 8 months after stopping the glucocorticoid, the exogenous source. And this is very important. All of that was physiology and endocrine discussion. Now let's talk about anesthesia. Those patients will come to your pre-assessment clinic, referred for surgery, not diagnosed with any endocrine disorder. So let's take some examples. You have a 48-year-old male listed for cholecystectomy, referred to a pre-assessment clinic because of refractory hypertension. So this patient has been hypertensive for a while and has been given several medications, and they are not responding. And on reviewing the patient, he was on 3 hypertensive agents with refractory hypertension: hemoglobin 127, platelets 263, white blood cells 8, sodium 131, potassium 2.9. If you see this patient coming for cholecystectomy in your pre-assessment clinic, what are you going to do? What do you think? This is a very important question, because this is how we usually miss those patients. And what I want to highlight is when you have this refractory hypertension with borderline low potassium, always think of high aldosterone levels, because this is how it happens. Refractory hypertension, hypokalemia, and it becomes severe if we are using diuretics to treat that hypertension. So that patient referred to endocrinology. Aldosterone levels were measured, renin levels were measured, aldosterone-renin ratio measured, and he was diagnosed with Kuhn's syndrome, caused by unilateral aldosterone secreting adrenal adenoma, and sent back for preparation for adrenalectomy. So remember, hypertension, refractory, hypokalemia, think of aldosterone. And to optimize this patient, the key is spironolactone, which is a physiological antagonist. It's a competitive antagonist to the aldosterone at its receptors in the distal convoluted tubules. And it's high dose, it's not hypertension dose. We give up to 400 milligrams daily to optimize these patients. And when we bring those patients to theater, you need to think of the intraoperative risks. Becoming hypokalemia theoretically prolong the action of the muscle relaxants, so you need to use a train of 4 to monitor them. Hypokalemia suppresses the baroreceptor tone, so hypovolemia should be aggressively treated intraoperative, otherwise those patients will become very hypotensive. And finally, complications, which is hypertension. Obviously, we'll treat it with the spironolactone, and we need to choose another antihypertensive medication. It has to be treating that pathway, so we have to be talking about the renin, so either ACE inhibitors or ARBs. Prolonged hypertension will lead to left ventricular hypertrophy and maybe failure, so those patients need an echocardiography to diagnose those problems. And the potassium will be low, so we need to top up if needed. It might be impossible actually to treat it preoperatively until the gland is removed. Another patient to talk about, which is a 52-year-old female listed for hernia repair, referred to pre-assessment clinic because of poorly controlled diabetes and suspected difficult airway because of her neck was a bit thick. On reviewing the patient, she had a BMI of 35 with a suspicious moon face. She reported thin skin that bruises very easily and purplish striae on her abdomen and thighs. And this is the clinical picture when the cortisol is high. This is a Cushing's syndrome. This is how it looks: moon face, purplish striae. You can see that. This is very, very characteristic, very, very thin skin and the purplish striae on the abdomen. Remember this diagram when you see a patient: moon face, buffalo hump, muscle wasting, very characteristic, stretch marks, weight gain, obesity, easy bruising, and the bone is very fragile. So those patients referred to endocrinology. They had screening, which is 24-hour pre-urinary cortisol, late night salivary cortisol, and short dexamethasone suppression test. Then this is a screening, so to confirm whether or not the patient has the Cushing's disease. Once it's confirmed, then we have to do a high dose dexamethasone suppression test by giving 8 doses of 2 milligram dexamethasone over 48 hours. And this should suppress the hypothalamic pituitary axis, That means the cortisol levels should go down. If it's not, then we diagnose where the problem is. If it's an adenoma in the suprarenal gland or the pituitary. And then we do an MRI for the adrenal glands and the pituitary to make sure that the position we have localized is correct, the adrenal or the pituitary. And remember that there's a circadian rhythm of the secretion of the glucocorticoids. That's why measuring them directly in the blood is not very helpful. They can reach down to 0 and up to many. And there is a very wide range. MRI, this is on the left, a normal pituitary gland. On the right, this is the pituitary adenoma that caused this problem. And this particular patient was diagnosed with a ACTH secreting pituitary adenoma, referred back to TSA surgery. TSA is a transsphenoid approach. Optimization, again, for those patients with Cushing's, spironolactone, because the glucocorticoids has a mineralocorticoid effect, so they have the same problem. Manage hypertension and blood sugar. Check obstructive sleep apnea because they have a lot of deposition of fat in their upper airway. Again, left ventricle. And the metrapone is a medication that inhibits cortisol synthesis in the adrenal cortex, but actually we don't use it for preoperative management or preoperative control of cortisol because this is not the aim. If we use it preoperatively, we might push the patient into crisis, adrenal Addisonian crisis, because we will deprive them from the source of the cortisol of the high levels that they have been used to for a long time. So the treatment of Cushing's syndrome is the removal of the source of the secretion. Intraoperative risks, again, reflux, positioning, take care, they are very fragile. We are talking about the bone and the skin. And if we are talking about iatrogenic Cushing's, this is important. Those patients are on external glucocorticoids, exogenous ones, and their axis is inhibited. So during surgery and if infection and stress, their body will need extra glucocorticoids. So we need to increase their doses or give them some more when we inducing anesthesia to keep those needs met. Another patient who's 55, male, listed for a Whipple's operation. He's known to have an Addison's disease under the care of endocrinology team. Addison's disease, we have discussed before. We have primary, secondary, tertiary, and iatrogenic, and we have explained these graphs. The primary can be autoimmune or metastatic cancer in the adrenal glands, or a patient who had a bilateral adrenalectomy. And for the secondary, it's hypopituitarism, and tertiary, it's hypothalamic lesion, iatrogenic, that we have exogenous glucocorticoids or other things. The diseases that you should expect to have patients with suppressed axis. When patient has a hematologic malignancy or organ transplant, rheumatologic disorder, inflammatory bowel disease, and inhaled corticosteroids, repeated intra-articular injection, all of them have proven to have inhibited axis. So all of these patients, you need to top up the steroids when you induce surgery. Low mineralocorticoids, it has manifestations. So when we lose the axis, sodium and water loss, hypovolemia and hyperkalemia. Low glucocorticoids, you'll have hypoglycemia, pigmentation of bulbar crease, and buccal mucosa, because when you have low glucocorticoids, the ACTH will be secreted more, trying to provoke the gland to secrete more glucocorticoids. But the ACTH itself acts like a pigmentation stimulant. It resembles the melanocyte stimulating hormone in the anterior pituitary gland, so it causes these pigmentations. And when we replace this low secretions, we have two medications that we need to think of, which are the hydrocortisone, which replaces cortisol, and the fludrocortisone that replaces aldosterone. Addisonian crisis, this is what we are trying to prevent. The patient will have abdominal pain, dehydration, hypertension, and vomiting. It can be due to absolute insufficiency, adrenocortical insufficiency. That means the patient is not being given the amount of glucocorticoids and mineralocorticoids they need. or the gland that doesn't secrete them. But the relative is when we give them the medications they are on, but all of a sudden the body needs have increased, like in stress, infection, patients on intensive care, or coming to surgery. Then we need to understand this very importantly. We have different types of corticosteroids. We have short acting, we have intermediate acting, and we have long acting. They are different in potency and duration of action. So we have what is called the equivalent dose. The cortisone, if we are talking about 25 milligrams, this is very equivalent to 20 milligrams of hydrocortisone. But when we're talking about something like prednisone, the equivalent dose is only 5 milligrams. And if you look at dexamethasone that everyone uses every day in the anesthetic practice, it's only 0.75 milligrams. So 20 milligrams of hydrocortisone equals 0.75 milligram of dexamethasone. And if you look on the right side of the screen, this is the half-life. The hydrocortisone half-life is 8 to 12 hours. That's why we give it several times a day. Dexamethasone can last up to 54 hours. And that's one of the reasons that we don't like to use dexamethasone in Addison's disease, because it's unpredictable. If we move on, the BMJ has published this glucocorticoid-induced adrenal insufficiency paper in 2021, and it's a very nice article. I recommend to read for more details. But the bottom line is, any patient who has been on 2 weeks of treatment of glucocorticoids or steroid treatment of prednisone equivalent dose. So this term is very important. So if those patients taking 5 milligrams of prednisone or any equivalent dose of any other glucocorticoid for 2 weeks or more, consider them suppressed access, and they need extra glucocorticoids externally when they come to us. That's why in 2020, and another recommendation to be read, it's very important, about management of glucocorticoids during perioperative period for patients with adrenal insufficiency. The bottom line, when the patient comes to theater, 100 milligram hydrocortisone on induction, and then 200 milligrams of hydrocortisone to be infused over 24 hours until the patient can tolerate to take oral, to have their oral medication back on. And when they have their oral medication back on, you double the dose for 48 hours, and then back to normal dose. Dexamethasone is not used because it lacks the mineralocorticoid activity. So even if it covers the cortisol, it will not cover the aldosterone function. That was all about the trivial hormones, if we can call them that. Now moving to the monster, which is the pheochromocytoma and the paraganglioma. The pheochromocytoma is a catecholamine secreting neuroendocrine tumor that arises from the adrenal medulla. The paraganglioma refers to its extra-adrenal counterpart. So it's the same tumor, but it's not in the adrenal medulla. It's in the sympathetic or the parasympathetic ganglion somewhere in the body. 10% of it is bilateral, 10% malignant, and 10% extra-adrenal, as we said, which is called paraganglioma. 0.5% of the population diagnosed by hypertension is because of having pheochromocytoma, undiagnosed ones. The signs are usually paroxysmal hypertension, headache, sweating, and palpitation. Sometimes you meet that patient unexpectedly in a very different operation, but you encounter unexpected hypertension and tachycardia. Head and neck paragangliomas are usually non-secretory, but cause compression manifestations. And most of those tumors are actually accidentally discovered on a CT. And that's why we call them incidentaloma, because we find incidentally discover them on a CT. The patient doesn't complain, or they have the symptoms, but they don't think that they need to go to the doctors to find why they have palpitation or sweating. And again, when we have those pheochromocytoma patients, we need to think of other tumors around the body because it's usually part of another syndrome. The most famous are the MEN, which is the multiple endocrine neoplasia, and the NF1, neurofibromatosis 1. Anyway, the pathway of metabolism of catecholamines is very important because it happens in two places, in the nerve endings and in the liver. In the nerve endings, the monoamine oxidase starts first, and then the catechol automethyltransferase, converting those norepinephrine and epinephrine to VMA. But in the liver, it's the reverse order. The catechol automethyltransferase starts first, giving us the metanephrine and the normetanephrine before the monoamine oxidase converts them to VMA. That helps with the diagnosis by using plasma and urine metanephrenes to diagnose this Pheochromocytoma, but all of them are not very sensitive. So as you can see, the highest sensitivity is the free metanephrine in plasma and in the urine. But measuring catecholamine itself is not very sensitive, and the metanephrenes, the total is not very sensitive. The VMA is not sensitive at all, so it's useless. So all the biochemical tests are suggestive, and we have lots of false positive results on them, including if we are using any of those medications, the patient might be false positive. So we can use a pharmacological test, which is called the clonidine suppression test. We give the patient 300 mics of clonidine, and we measure the norepinephrine before giving it and 3 hours after. And we just need to understand what we are trying to achieve from this test, because the pheochromocytoma is not the same as the normal medullary tissue. The normal medullary tissue is under the control of the sympathetic nervous system. So stimulation from the sympathetic nervous system gives the signal to the nerve. The preganglionic release acetylcholine. The acetylcholine will stimulate the vesicles to secrete the adrenaline and the noradrenaline. But those pheochromocytoma are not under the control of the same pathway. The secretion is autonomous. They don't need this stimulation. So what we're trying to achieve from the clonidine test is that we give clonidine and monitor the norepinephrine. It should go down. The levels of norepinephrine should go down. If it doesn't, that means this secretion is autonomous, is not related to this axis. That means it's a pheochromocytoma. And after diagnosing, we need to know where these hormones are coming from. So we do CT, MRI, and if we are suspecting cancer, it's a PET-CT. Or we can use a radioactive iodine labeled precursor, which is the iodine 123 meta-iodide scintigraphy. So we inject that, and then we try to localize which part of the body is creating this radioactive material, because it might be a pheochromocytoma or a paraganglioma in a ganglion somewhere in the body, and we can't see on the CT. So the scintigraphy will help us diagnose this. The pathophysiology and the impact of this pathophysiology on us from pheochromocytoma, we need to focus on. So continuous catecholamine release in the circulation that will lead to continuous vasoconstriction. That means tight circulation. All the blood vessels are at maximum contraction. And when that happens, the body will respond by decreasing the blood volume. So we have a hypovolemia. And depending on how much volume we are losing, is it plasma or red blood cells, we will have a hematocrit and hemoglobin. But we cannot use the hemoglobin concentration and hematocrit value to diagnose hypovolemia here, because they would be normal or high. If the patient is anemic, the hemoglobin will be normal. If the patient is not anemic, the hemoglobin will be high. So hypovolemia is different. The other thing is the perfusion pressure. Because those patients are in continuous hypertension, the perfusion pressure of the important organs in the body will be reset in another point. So you need higher blood pressure to perfuse the heart. You will need higher blood pressure to perfuse the kidneys. You'll need higher blood pressure to perfuse the brain, if we are outside the autoregulation mechanism of the brain. And we need to look for the end organ damage. And most importantly here is the heart, because it gets affected very quickly. Coronary artery disease, left ventricular hypertrophy and function, and right ventricular hypertrophy and function in the diameters. This is very important. So every patient coming with pheochromocytoma, ECG, because they usually have this arrhythmias, and echocardiography to diagnose everything in the function of the heart. We need to avoid the crisis. If it happens, it's fatal, mostly fatal, very dangerous. There are two types. One of them is mild and the other is severe. When the severe one happens, it's usually fatal. Multi-organ failure, cardiovascular collapse. So preoperative preparation for those patients coming for pheochromocytoma excision. The key is alpha blockade. All the patients come to us, phenoxybenzamine, alpha-1 blocker, 1 to 4 weeks, starting at 10 milligrams BD and up to 100 BD. Assess the blockade, the alpha blockade, and discuss side effects with the patient and endocrinology. And I forgot to mention that these cases are MDT, multidisciplinary team approach. It includes the anaesthetist, endocrinologist, and the endocrine surgeons. It's very important. Sometimes we involve cardiologists if we find any other problems. After starting the alpha blockade, the treatment goals are to normalize the blood pressure, prevent paroxysmal hypertension, and to abolish tachyarrhythmias. Side effects of an adequate phenoxybenzamine dosage. So we know that when we give the patient the phenoxybenzamine, they will get side effects and they need to be prepared for it. And actually some of the side effects are important for us to detect to make sure that we have proper alpha blockade. One of them is orthostatic hypotension. So we need to make sure that the patient gets postural hypotension. That means they have lost the vasoconstriction reflex that happens when you stand up. And that means we are happy with the alpha blockade. Tachycardia, it happens with alpha blockade. Nasal congestion is very important. I have to ask all the patients on the day of surgery whether or not they have nasal congestion. Dry mouth, diplopia, and ejaculatory dysfunction. Those shouldn't be a big problem if we are doing them for 2 weeks. But if the patient is very intolerant, we can use doxazosin instead of a phenoxybenzamine, but I wouldn't recommend. After achieving a proper alpha blockade, we can think of beta blockade, and usually selective beta-1 like atenolol, metoprolol, or combined alpha-beta like labetalol. And if those measures do not do the complete control that we wish for, there is a third agent that we can add, which is called alpha-methyl-paratyrosine, which blocks the tyrosine hydroxylase enzyme, which is an important part in the pathway of the synthesis of epinephrine and norepinephrine. So we can say it's not a blocker, but it's a slowing mechanism. It just slows the rate control. This is what we do in our center. We start the phenoxybenzamine and we give the patient 600 milli equivalent of sodium chloride tablets with it. And when they have this, they will drink more water and replace the volume. So the problem with the tight circulation is once we start to give the alpha blocker and the capacity of the circulation increases, they will become profusely hypotensive. So we need to replace that volume and keep them euvolemic. And when the patient is not in hospital, they are at danger of being very hypotensive without correction. And this is what we try to achieve with the sodium chloride tablets. They take the sodium chloride, they drink a lot of water, and this fluid remains in the circulation and the interstitial tissue. And this is how we start. And then we start reviewing the patients in our pre-assessment clinic, and we measure the postural hypertension. So if we have a postural hypertension less than 15 millimeter mercury and a heart rate less than 100, we keep increasing the phenoxybenzamine dose and the sodium chloride tablet dose until we achieve what we need to achieve. And then we admit all the patients electively 3 to 4 days before surgery for the final fine-tuning to keep them euvolemic and make sure the dose of the phenoxybenzamine is correct and we have achieved alpha blockade, and do the final bloods before the operation. And in terms of anesthesia, risky points. During the pheochromocytoma surgery, the induction, because the response to instrumentation is enormous, we'll find swings in hemodynamics and instability that is just overwhelming. Intubation is the same. Tumor manipulation, every time they hold the tumor and push, expects a gush of adrenal and noradrenaline. But luckily, the adrenal and noradrenaline, as we know, have very short half-life of 2 minutes, and then the catechol orthomethyl transferase and the monoamine oxidase will do the job. That reminds me to remind you that patients who have catecholamine excess or pheochromocytoma are not allowed to have any type of monoamine oxidase inhibitors. The tumor manipulation, as we said, Every time they push, every time they move, expect some instability. And then the vein ligation, which does the reverse. So on induction, what we should expect is hypotension, because once we induce this patient who is used to very high concentration of catecholamine circulating in the blood, they will lose this sympathetic drive with induction. They can crash. That's why we need to make sure that we have good alpha blockade and euvolemia before induction. Intubation is the other way around. Expect with instrumentation a spike of blood pressure. Tumor manipulation, more spikes. But the vein ligation is the other thing, because once we ligate the vein, we have lost the continuous supply of catecholamine into the circulation. And that patient who was accustomed to high concentration of catecholamine just lost the source. So expect drop of blood pressure and instability. In terms of surgical problems, remember that it's now laparoscopic surgery. It's done in this position, which is a kidney break position, lateral decubitus. The venous return will be affected beside everything else, and the ventilation might be compromised. A couple of months ago, I was asked to go and give my opinion about a complication happened with a patient in a Pheochromocytoma. And that patient died 4 days after the operation because a fractured T8. So on that position, the surgeon kept asking the anaesthetist to increase the brake to access the kidney. And then they have done the surgery, went uneventful. The patient was put back on bed, stayed on the ward. Day 4, getting off the bed, movement of the fracture that was undetected, spinal cord transection, and the patient died later. So take care. When I go in, what I prepare all of these: epinephrine, different doses, norepinephrine for infusion. I usually need that after the vein ligation. Metaraminol, don't worry about it. I know it's just in the UK, but it's a brilliant alpha-1 agonist. Glyco, atropine, labetalol infusion and boluses. GTN to manage the spikes of blood pressure during the squeeze of the gland. Some other people prefer sodium nitroprusside, but I like the GTN more. Dobutamine, phentolamine, boluses. But usually we don't need it if we actually have done a good job preparing the patients with alpha blockade, and esmolol infusion for heart rate. The procedure I do: awake arterial line, of course, because I need to keep an eye on the blood pressure with every instrumentation. Awake thoracic epidural if this is going to be an open surgery, which we haven't done in a long time. Large dose opioid after induction and before intubation to cover. So what I mean is, when I do the induction, I do it with low dose opioid because I don't want to crash the blood pressure. But once I'm sure that there is a stability in the hemodynamics, I give more opioids before intubation because the instrumentation of the airway will push the blood pressure a bit higher. And I keep the metaraminol infusion in the background in case I need to bolus it to keep the blood pressure up. I usually put a central venous catheter, keep the patient warm, not to stimulate the sympathetic system, put a urinary catheter, transesophageal echo, and minimally invasive cardiac output monitors just in case we diagnosed a pre-existing cardiac complication from the pheochromocytoma, so we can monitor the heart during the procedure. Now, this picture is from my anesthetic chart, and during the tumor manipulation, an asystolic blood pressure hit 350 millimeter mercury. And it went down after 3 or 4 boluses of phentolamine and then GTN. Here, this is another patient, pheochromocytoma, and if you can see this slope down here, this is just after the ligation of the vein. The blood pressure dropped down from 200 down to 100 in about 3 minutes. This is another patient with a flat trace with no ups and downs. So my question, what do you think this is? Of course, you can't answer, so I'll answer. This is an unsecretory adenoma. So this tumor wasn't a pheochromocytoma. It was an adrenalectomy for an unsecretory adenoma. That's why we don't have these swings of hemodynamics. Post-operative, remember to prepare some dextrose, because once you remove the adrenal glands, they usually become hypoglycemic. So we replace that with some dextrose until they recover. Glucocorticoid replacement, as we mentioned before, especially if we are talking about bilateral adrenalectomy, and keep them on high dependency unit overnight. That's it from me today, and thank you for listening. Stop sharing so you can go back. Thank you.
Thank you very much, Dr. Ahmed, for this lovely presentation. Now it's time for a question. If anyone got a question, please put it on the chat form.
If you please, I'd like to thank Dr. Rifai for this very nice lecture. And I think one of the important issues in our anesthesia is a challenge when we are going to do anesthetize the Pheochromocytoma. Dr. Rifai, I'd like to ask you about the preoperative management. And this is, as you mentioned, is very, very important. This job is our job as anesthesiologists, or a combination between us and endocrinologists, or it is sole job of the endocrinologist, and we are following the endocrinologist advice, and for how long we should prepare this patient, I mean the duration for giving the drugs preoperative, because preoperatively, I think in this issue is the main issue for this procedure. Thank you so much.
So preparing those patients, as I mentioned, is an MDT approach, multidisciplinary team. We all are responsible for it. It depends on who discovered the patient first. So if the patient was discovered by an endocrinologist, they start giving them the proper medication and refer them to the surgeon, who refers them to the preoperative assessment clinic of anesthetics. And then we MDT the patient. So we have a meeting of the three of us, anaesthetist, endocrinologist, and the surgeon. Plan the treatment, the specific treatment for each patient, and then start alpha blockade them, all of them. The alpha blockade, as I mentioned, at least for 7 days, and sometimes it reaches 4 weeks, a month. And we bring the patient to the endocrinology pre-assessment clinic every 5 days to check the postural hypertension, the heart rate, and their eupholemic. And if they need, we can give them IV fluid in the clinic to make sure that they are topped up. Once we achieve, at any point, once we achieve the proper alpha blockade by finding the proper postural hypertension and all the other side effects, we are happy that this patient is ready for surgery, even after a week, 10 days, 2 weeks, a month. Once we reach this, the patient comes to the anesthetic pre-assessment clinic for the rest of the problems, because the patient doesn't have only the Pheochromocytoma. It can be ischemic heart disease, can be COPD, can have other things. So we need to reevaluate everything again. And once we all happy, we MDT again, we discuss, and we decide that this patient is ready. We admit them under endocrinology 3 days or 4 days before surgery. And then they manage them in the hospital. So when they are admitted first, they are admitted under endocrinology, do the management until the day of surgery. Then they will be under us. Post-operative, they are under both of us, anesthesia and endocrinology, because they spend 1 day in high dependency unit. I hope this answered the question.
Thank you.
Dr. Amr,
we got a question from Yasser to yourself, Ahmed. What is the management if the patient coming for emergency and the patient not diagnosed that he has pheochromocytomas, which means like persistent hypertension intraoperatively? What would be your management in this situation? Would you suspect it as first option, or?
So we first need to define what emergency is. Is it an endocrine emergency as a hypertension, or?
We can assume it's a different surgery, nothing to do with endocrine.
And Pheochromocytoma, are we talking about other accidents? Can you hear me?
Yeah.
Okay. So if we are talking about an emergency surgery that's not related to pheochromocytoma, they go straight to theater and we prepare all the medications. If they're not diagnosed, we don't know. But if they are diagnosed with pheochromocytoma and coming with a pheochromocytoma emergency, which is high blood pressure and tachyarrhythmias and heart failure or whatever, there are two opinions about this. The first say that the pheochromocytoma crisis is an endocrine / surgical emergency. So we bring them to theater and take this source of secretion off. There's another opinion which says that pheochromocytoma crisis is not a surgical emergency. They have to be admitted to intensive care and medically managed until they are stable, and then bring them to theater. And the advocates of this say that the mortality rate is very high when we take pheochromocytoma crisis to theater. So pre-optimizing them, give them a better chance. And this is the latest. So now people consider the pheochromocytoma crisis is not a surgical emergency. It's an endocrine emergency, but it's not a surgical emergency.
Please, Dr. Amr, I have a comment, short comment. Please. Dr. Ahmed, please, you can summarize now and arrange. If I have a patient with pheochromocytoma and plan for example, a fracture femur, urgent cesarean section, would you have to tell us if you have a special protocol for such a patient, which is a pheochromocytoma patient, for non-endocrinological or non-surgery for his case, original case, pheochromocytoma? Please summarize it, and if you have a special protocol for such cases, please, for our student, please, or junior staff, please, Dr. Ahmed.
So, to cut the long story short, if a patient have a pheochromocytoma, they don't come for any elective surgery. If they have pheochromocytoma, the pheochromocytoma needs to be taken out first. From the things you mentioned, the only thing that might need the patient to come in surgery is to deliver a baby. Otherwise, everything else can be postponed. And in this case, we can actually alpha blockade the mother before delivery. And that helps with the blood pressure control. But again, the protocol is the same because the intraoperative management will be the same. Have everything ready, all the list I've mentioned, which is what was in my slide, all those medications ready, all the access ready, and it's the same approach as if we are doing a pheochromocytoma.
What the type of narcotics do you prefer during the induction of the pheochromocytoma during the operation? Type the short-acting one or the long-acting one?
I use remifentanil infusion to keep it in control.
Okay.
There is another question for you, Ahmed. You mentioned you do not prefer doxazosin. Can you explain why?
It's just a matter of potency. So the phenoxybenzamine is much more potent and effective as a first-line treatment. So we shift to doxazosin just in case the patient is very intolerant to the side effects, but it's not as effective as the phenoxybenzamine. So I prefer the phenoxybenzamine to make sure that my patient is alpha blocked when I put them on table.
Okay. You mentioned clonidine in your talk as a way of diagnosis, which brings us to the question of the fashionable drug dexmedetomidine. As we can give it as an infusion. Has it got any role? Has anyone used it?
No, I'm not aware of any research about that. But again, the clonidine is a diagnostic test because it works on the normal suprarenal medulla, not on the pheochromocytoma.
Yeah.
So we try to suppress the normal suprarenal medulla to keep the secretions from the pheochromocytoma high.
Yeah.
So neither clonidine nor dexmedetomidine can affect the secretion of the pheochromocytoma.
I mean, as a management intraoperatively to control.
It's the same thing. Both of them are alpha-1 agonists. So they try to stop the preganglionic stimulation of sympathetic nervous system. But the pheochromocytoma is not under the control of the sympathetic nervous system. It's an autonomous secretion. So using anything to stop the pathway doesn't help. We need to find a target organ, which is the blood vessels. That's why we use direct vasodilators like GTN and sodium nitroprusside.
Okay.
Yes.
Any more
No
questions
other
from the auditors?
yeah. I want to ask you, Dr. Ahmed, but out of our of your lecture scope, please also for protocol or arrangement of thyrotoxic pregnant female planned for a cesarean section. Can please you can apply it for us all? Please, your protocol for both, please, for diabetic and thyrotoxic pregnant planned for cesarean section. Because this is this is our daily practice and more common cases. Thank
you. We can do a series of lectures for every endocrine problem, but talking about every single gland is a big topic.
Yeah,
we can't take just those from it, but I promise we can prepare something for that.
I've got another question for you, Ahmed. What type of muscle relaxant do you use?
So there is a theoretical concern about using atracurium in pheochromocytomas because it's thought that it will release histamine, which might increase the adrenocortical medullary stimulation and participate in the instability. But this is actually theoretical. Yep. Some people prefer to use rocuronium to avoid using atracurium, but I personally have been using atracurium with no problems.
Another question is about postoperative mineralocorticoids, either routine, I guess.
So as I said, the cortisol mimics the hydrocortisone mimics the cortisol effect exactly, which has a weak mineralocorticoid activity. So the supplementary hydrocortisone post-operative gives us both the effect of glucocorticoid and mineralocorticoid until the endocrinologist assess the axis to make sure that the other suprarenal gland is functioning enough and the axis is not suppressed. Okay. But if we do bilateral adrenalectomy, if a patient got bilateral adrenalectomy for any reason, they stay for life on both hydrocortisone and fludrocortisone, which is the aldosterone supplement.
Perfect. We've got another question about a patient with congenital adrenal hyperplasia. What are the anesthetic concerns and consideration? Congenital adrenal hyperplasia.
It's the same. It's hypersecretion of aldosterone. The hyperplasia is a cortex. It's not a medulla. Mm-hmm. Bilateral adrenal hyperplasia is a Conn syndrome or a Cushing syndrome, and it's the same. Okay. High aldosterone levels, high cortisol levels, sodium and water retention, hypertension, maybe affecting the left ventricle, hypokalemia that needs to be treated, and plus the other concerns of Cushing syndrome.
Perfect.
Any other questions?
Dr. Amr, a few questions. Tanya?
I think that's all the questions we got so far.
Okay.
I hope people enjoyed the lecture and find it useful. So what is your take-home message for us?
Take-home message. Endocrinology needs understanding of physiology, and this is very important.
Yeah.
So if you're going to do any endocrine work in anesthesia life, go back to the physiology.
Okay. Okay.
Very useful message. Thank you very much.
Thank you. Thank you. really many thanks, and it was great honor for us in Elrefaey Anaesthesia Club to have you with
Thank you
us
all.
today.
Thanks for the invitation, Dr. Safa.
Thank you. Many thanks for you. Highly fascinating lecture, amazing one. Many thanks for you, Dr. Ahmed.
Yeah, thank you very much.
Thank you, Dr. Amr.
Thank you very much, Safa. It's great to meet you again.
Thank you. And I'm sorry for interruption in the beginning.
These things happen in the technology. It's always the case.
Yes, out of our hands.
Yeah, nothing you can do.
Thanks, Dr. Isam. Thank you, Dr. Saab.
Thank you so much. Just as
and all our attendees.
Just at the end, Dr. Safa, Dr. Amr, Dr. Rifai, just to say thank you for all the attendees and for the panelists. And just to announce that, inshallah, next Saturday in the same time, Cairo time, 8 o'clock evening, PM. It will be, inshallah, the lecture of Dr. Adel Shimi about the congenital diaphragmatic hernia management, inshallah. Sorry for the what happening in the technical support today, and we promise all the attendees and all the group to enjoy, inshallah, next week with this lecture. Thank you so much.
Thank you very much.
شكرا دكتور عمرو، شكرا جزيلا لحضرتك.
نشوفكم بخير ان شاء الله.
شكرا ان شاء الله. شكرا جزيلا. مع السلامه.